Time for another Puscast. This is covering the last 2 weeks of August 2012. A couple of things. First, I'm recording this outside, so you'll hear some extraneous sounds. Cars going by, the kids shooting hoops, an occasional crow, and I'm sure you'll hear the goddamn dogs that the neighbors have. Bark, 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 bark. I hate dogs. Actually, I hate owners of dogs. Next thing to mention is that my book, The Puss Whisperer, my first year's collected essays from the blog Rubor Dolor Kalor Tumor, are not only available now on Kindle and at Smashwords, but the Nook and iTunes. 99 cents. Such a deal. And finally, I'm trying to be more of a presence on Twitter and Facebook. Although I have to admit, I find Facebook to be completely opaque. But that is probably one of the many signs that I'm just an old geezer who wears an onion on his belt, as was the style of the day. With that in mind, we will now move on to the literature, to the sounds of crows, cars, dogs, and basketball. You tend to think of evolution as a long-term issue, millions and millions of years to go from our ape-like ancestors to, say, Mitt Romney. Not so much a leap after all. And in microbiology, though, these things tend to happen over months and years in what's sometimes called microevolution. The study was quite interesting, and they looked at the use of antibiotics during the seasons and subsequent isolation of resistant organisms. And they found that as ampicillin usage went up in the wintertime, as did ciprofloxacin usage go up in the wintertime, that 1 or 2 months later they saw resistant infections from these organisms. They also saw that fluoroquinolones and macrolides drove a little bit of MRSA with anywhere from a 1 to 2 month lag as well. Of course, the motto of all right-thinking skeptics, i.e. good doctors, is that association is not causation. But it is interesting how when antibiotics are used in large amounts seasonally, that shortly thereafter resistance goes up in the community. They also point out that given that hospitals are but a piddly drop in the water compared to overall antibiotic use, that curtailing antibiotics in the hospital probably won't have great impact on the wider distribution of resistant bacteria. I've made my first Mitt Romney joke of the season. I'd make jokes about Obama, but he's not done anything, so it's hard to make jokes about Mitt. I have noticed over the years as I've given lectures that I've never received a complaint about making jokes about, say, Clinton, who was an endless source of amusement. But you always get complaints if you make jokes about Republicans, because Republicans are fundamentally thin-skinned, whiny babies. All diseases, well, at least all interesting diseases, are infectious in nature. I've talked in the past how certain viral infections are associated with obesity. And there's an interesting study that showed that patients on endocarditis who received vancomycin were more likely to put on the pounds than patients on beta-lactams. And there's this whole growing literature on how your microbiome, what the bugs are in your gut, may help determine whether or not you become obese or not. Of course, it doesn't help if you eat like a pig. But this study looked at antibiotic use in early infancy and found from data of 10,000 kids that if you received antibiotics before 6 months of age, you had an increased risk of obesity in childhood. Now, again, what's our motto? Association is not causation. But it is certainly interesting that if you mess up a kid's microbiome early, potentially you could lead to obesity later. And just between you and me, when I go into the doctor's lounge and I see those maple bars on the platter, it's the bacteria in my gut that are making me eat it. Which reminds me, I do also have a new website. It's on Squarespace, and you can still get there by the old URLs, but the current URL through Squarespace is edgydoc.com. Every time I ask my youngest son for a bit of popular culture information for a blog or a podcast, he always says, "Being edgy again, Dad?" So, edgydoc.com. The home of pussware. Those of you who are my listeners and live in societies with rational healthcare systems probably won't care. But there was a study that looked at the use of vancomycin either as continuous infusion versus standard intermittent dosing in patients with MRSA. and essentially found the same outcomes in both patients. I think the benefit of this may be in the outpatient setting, where sometimes patients without insurance have to come in 2 or even 3 times a day if they're IVDUs. It might be nicer just to hook them up to a closed system, run the drug in for 24 straight hours, and then have them come in for an exchange. But I can't see in the inpatient setting that there's any advantage of continuous over intermittent infusion of vancomycin. I am, of course, old, and old people can't change. I still haven't figured out, for example, how to use troponins in evaluation of myocardial injury. It seems that everybody admitted to the hospital has a positive troponin at some point. The issue of procalcitonin is another test that I have yet to routinely use in my practice. I think, however, there may be benefit as part of an antibiotic stewardship program, and there was a recent meta-analysis in Clinical Infectious Diseases on the use of procalcitonin in acute respiratory infections. And they found that studies that used procalcitonins overall dropped the use of antibiotics by about half, from 8 days to 4 days, which is pretty good. I'm still not certain it should be used routinely in the average patient coming into the hospital, but that's probably just the old geezer in me talking. But certainly this meta-analysis would suggest it would be a benefit. Of course, the theory behind a meta-analysis, as I've said so many times before, is you take a whole series of cow pies, you combine them into one giant cow pie, and you get gold. And you think that's bad, you should feel sorry for my residents, because they have to listen to the same jokes every day for 3 years. You only have to listen to me every 2 weeks, and then you don't have to. A new immunodeficiency reported out of Thailand/Taiwan. Which is it here? Both. They found a bunch of patients who had both disseminated rapid or slow-growing mycobacterium or opportunistic infections with and without non-tuberculous mycobacterial infections. They worked them up for immunodeficiencies, including AIDS, and didn't find anything. But further evaluation showed that what they had was neutralizing anti-interferon gamma autoantibodies in 88% of the patients. And if they had an opportunistic infection and a mycobacterial infection, 96 of these patients had autoantibodies against gamma interferon. Pretty interesting. Every once in a while, you see a patient who clinically has AIDS, but you work them up and HIV, etc. is all negative. Now we'll have to send off their lab for anti-gamma interferon antibodies. Remember, the key is opportunistic infections without other explanation, or especially opportunistic infections like you see in AIDS plus disseminated mycobacterial infections. Whether other populations out of Thailand and Taiwan have this disease is yet to be determined, of course, but that sure sounds like a potential board question. Interestingly, these patients did not get better on antibiotics, so it suggests that they need therapy directed against the underlying antibody issue. We all know that women who are pregnant tend to get worser influenza and are more likely to die. Why, pray tell, is that the case? This study looked at the lymphocytes of pregnant women and non-pregnant women and pregnant women who had had the vaccine, and found that pregnant women were less likely to respond with a interferon alpha and gamma in response to influenza, and that those who had vaccinations did a much better response, giving credence to the fact that women who are pregnant and get flu are less likely to respond to influenza, and that the vaccine should be protective in preventing them from dying. As of the end of August, there have been almost 1,600 West Nile cases and almost 70 deaths due to the virus in the United States, making it the worst year for West Nile since the virus hit the shores of America in the 1990s. One wonders, that one being me, if the virus has gone some sort of mutation to make it more virulent, or what the deal is with that we're having such a bad season this year. I'm sure those articles will be out in about 2 years. Why, you might ask, am I sitting outside doing this podcast on a beautiful summer evening? Well, yet another great thing about the Great Pacific Northwest is we don't have any West Nile yet in the Willamette Valley, at least not yet this season. Personally, I think it's the microbrews that keep them away. And as long as you're being paranoid about environmental pathogens, there's hantavirus in Yosemite. And for those of you in primary care, the CDC suggests that all baby boomers get tested for hepatitis C. The years of sex, drug, and rock and roll have caught up for those born between 1945 and 1965. Those of you born after 1965 evidently know the benefit of not shooting up and using condoms. Why do people die and from what? Well, this looked at the results of death from a variety of viral infections in the elderly, and I'll just read you the results from Journal of Infectious Diseases. Influenza A and RSV was significantly associated with mortality in all age groups. Influenza B and parainfluenza tend to kill those over 75. Norovirus killed those over 85. The proportion of death attributable to seasonal virus was 6.8% in those over 85, 4% in those 75 to 84, and 1.4% in those 65 to 74. So influenza A, B, parainfluenza, norovirus, and RSV are significant pathogens in the elderly, and the older they get, the more likely they are to die of the disease. Of course, the anti-vaccine wackaloons say that influenza doesn't hurt anybody and it's good to get infected. Pay them no mind unless, of course, you want to inherit from an elderly and wealthy relative and then get influenza and pass it on to them. So, two men in Missouri, done got bit by a tick. They then had fever, fatigue, diarrhea, thrombocytopenia, and leukopenia about 5 to 7 days later. Of course, they thought they had Ehrlichia, but they didn't. Instead, they found evidence of a new virus in the Bunyaviridae family called a phlebovirus. So there's now a new tick-borne virus in southern Missouri that causes a febrile illness that, like the anti-gamma interferon antibody disease, will almost certainly show up on my next boards, and I'll certainly not remember it. Because I don't live in Missouri. I tend not to remember the diseases not found where I live. As you probably know, strep bovis now has a bunch of new names. There's strep galactolyticus pasteurianus. Why they call a strep of the rectum pasteurianus, I'll never know. Strep gallolyticus subspecies gallolyticus, strep infantarius subspecies coli, and strep infantarius subspecies infantarius. They looked at all the patients that had bacteremia in their institution, a whopping 24 cases, and found that irrespective of which prior strep bovis they had, there was a strong association with both colon pathology and or endocarditis. This is going back and forth, as some studies have suggested that some new speciations of strep bovis are less likely to be associated with colonic pathology and others more. The general consensus would appear to be that if you have a patient with one of the strep bovi, a gallolyticus or an infantarius, you should probably look for endocarditis and have them ride the wild snake to make sure they don't have a colon cancer. The one reason I'm glad I've had a colectomy is I'll never have to drink Go Lightly again. God, that's nasty stuff. Of course, my colleague suggested that instead of mixing it with water, you mix it with white wine. And maybe that would indeed render Go Lightly more palatable. But I'm so glad I never have to drink that swill again. Interesting study about C. difficile prevention. They looked at patients on ceftriaxone versus ceftriaxone plus doxycycline. And those who received doxycycline had much less C. difficile than those who didn't. They found that for every day of doxycycline receipt, there was 27 less C. difficile compared to those who did not receive doxycycline. One thing would be that maybe doxycycline plus ceftriaxone would be a better alternative for community-acquired pneumonia therapy, although the predominance of data suggests that a ceftriaxone plus a macrolide has better outcomes. The other issue would be the treatment of outpatient soft tissue infections and boils. I have been using far more doxycycline than TMP sulfa for a variety of some theoretical reasons. Doxycycline has been my go-to drug, and perhaps I've inadvertently been decreasing the amount of C. difficile in my community. I recommend a lot of oral doxycycline for both soft tissue infections and community-acquired pneumonia because it's cheaper than the quinolones, that's for sure. And I may be getting some inadvertent benefit for C. difficile as well. Some things aren't worth a big discussion. E. coli that causes extra intestinal illnesses, sepsis, etc., may be likely food-borne. Patients with community-acquired pneumonia due to strep pneumo who are bacteremic have 3 times the mortality rate of those who do not. A pneumonia in a new transplant patient increases the risk of allograft loss by about 75%, which is pretty good. And there was an outbreak in heroin users of anthrax in Scotland in 2009 through 2010 that affected 82 people. That's 82 more cases of cutaneous anthrax than I've ever seen. Remembering that anyone who uses the term strong, big gun, or powerful in reference to antibiotics is an idiot and knows nothing about antibiotics. The converse is they're truly crappy antibiotics, and the archetype is vancomycin. This is another study that looked at dialysis patients who had MSSA and compared outcomes in patients who received cefazolin, although my pharmacists prefer cefazolin or vancomycin. Guess what? Those who got cefazolin for their MSSA had a 38% lower mortality rate. Pay attention here. Never, ever, ever use vancomycin against an MSSA unless you have a compelling reason to use a beta-lactam. Now you may say that, well, I'm going to give my vancomycin because it's more convenient. You can give cefazolin conveniently. It's a simple dosing schedule from the Clinical Infectious Disease article from a couple of years ago. If there's a day between dialysis, you give 1 gram. If it's 2 days between dialysis, you give 2 grams. And 3 days between dialysis, you give, that's right, 3 grams after dialysis. This study published in the Journal of the American Society of Nephrology is one of several now that show that if you treat MSSA in a dialysis patient with vancomycin, you're going to have worser outcomes. And an interesting little tidbit about staph carriage. They did a left and right NARS culture in 251 patients. If you were a carrier, you were usually carrying it in just one nostril. And if you carried it in both, you had a different strain in each nostril 20% of the time. So as they say, nostrils belonging to a single individual, I actually have nostrils belonging to several people in my back pocket, should not be assumed to be homogeneous with respect to carriage of Staph aureus. Makes you wonder if there's a different ecologic niche in each nose, or if you pick your nose with different fingers leading to different colonization. So a left nose pick gives a unique strain compared to a right nose pick. How long to treat pyelo? Well, this study in the Lancet out of Sweden looked at the treatment of pyelo in women who were not pregnant and otherwise healthy with ciprofloxacin, 500 twice a day. They received it for either 7 days or 14 days, and no difference in outcomes. Cutting down your cipro treatment by half would certainly be a significant decrease in the antibiotic pressure for resistance to both cipro, and of course ciprofloxacin drives MRSA and C. difficile. And some final hodgepodgery to finish this up. I said I couldn't cope with procalcitonin. Now they found another marker in the blood of septic patients, the soluble urokinase type plasminogen activator receptor. The higher it is, the more likely you are to be septic, and the more likely you are to die. So I'm sure that will be released in the not too distant future. There's an MMWR report on tattoo-associated mycobacterial skin infections here in the Great Pacific Northwest. there was a case of abscessus in Chelonia. There's also been cases of those two organisms in Colorado, Idaho, and New York from being inked. I also don't understand tattoos, but that is another sign that I'm getting old. There's also some reports of patients with amoebic encephalitis from using tap water and irrigation devices. This is usually seen in swimmers, but the recommendations are if you're going to irrigate your sinuses, don't use tap water in your neti pot, if a neti pot is what you're using, but use sterile water. And then interestingly, an article on filariasis and lymphedema. They did a series of patients where they received doxycycline, and regardless of whether or not they had active infection, there was improvement in their lymphedema. So they recommend the patient with stage 1 to 3 filarial lymphedema should get a 6-week course of doxycycline, perhaps yearly, perhaps every other year, regardless of their infectious state, to help control their lymphedema. I thought that was quite interesting. And that, I think, is going to end it. It's the end of another Puscast, a review of the infectious disease literature. The references, of course, are online. If you're bored, you can go on iTunes and write me glowing reviews. I'm now going to do the Twitter and the ever-opaque Facebook, as I mentioned at the beginning. And my book, The Pus Whisperer, complete with all new spelling errors and weird grammar, is now available on the Kindle, on the iPad, and on the Nook, and of course in any number of formats at Smashwords. Otherwise, you can go to my website, edgydoc.com, to find links to all of my growing multimedia empire. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of your patient. I shall continue to follow along with you. Thank you. In dictation, goodbye.